You can start, ma'am.
Sir, shall we start, sir?
Yeah.
Yes.
Please start.
Good morning, everyone. On behalf of the IE and Young Neurology Forum, it is my pleasure to welcome you all to this session. Today, we have a very interesting session, the Journal Club. So, this is all about learning to think like a neurologist. So, we are going to study from experts today on how to analyze a paper and how to translate this research to meaningful clinical practice. So, over to Jyotsna. Please take over the proceedings.
Yes, thank you, Saraswati. Good morning, all, and welcome to our third session of Young Neurology Forum series. And as Saraswati told today, it is an offbeat session. Usually we have academic case discussions, but the way the session was envisioned was because I benefited as a mentee from a person who taught his students how to critically analyze, not just neurology, but other research, not in India, through the world. So I bring to you one such doyen in neurology, especially so in pediatric neurology and pediatric epileptology, who has shown his willingness and enthusiasm to moderate this session as a senior moderator. I welcome Vinay and KP sir. He is the professor and head of the Department of Pediatric Neurology at Amrita Institute of Medical Sciences, Kochi. He is the director of Amrita Brain Center for Children and a specialized center for pediatric neurology. I welcome Vinay sir and thank you for being willing to share your time with us. So,
thank you, Jalsa. Thank you, Saraswati, for this invite.
Yes, sir. I invite Dr. Jitupam Baisya. He is an associate consultant, senior consultant neurologist at AIIMS Guwahati. He has had experience in neurology and epileptology from Sri Chitra Tirunal Institute of Medical Sciences, PGI Chandigarh, now gone back to his roots and serving AIIMS Guwahati. Welcome, sir. Thank you for being willing to moderate the session.
Thank you, Dr. Jyotsna. Thank you, Dr. Saraswati. Thank you.
Yes. I welcome a dear friend, Dr. Jasmine Parihar. She is the Assistant Professor of Neurology at AIIMS New Delhi. Again, a young but a very bright neurologist who has shown the interest to moderate the session. Thank you, Dr. Jasmine.
Thank you, Dr. Jyotsna. Thank you, Dr. Saraswati.
Thank you, Dr. Shivam Murk is a just passed out resident in neurology from AIIMS New Delhi. Thank you for the effort. Dr. Kaushik is a consultant pediatric neurologist. He has completed his DM in pediatric neurology at AIIMS Delhi. And both of them have come out in flying colors and they have accepted this responsibility to present and to enrich us with their knowledge and expertise. And thank you all the moderators and presenters for showing your interest in this session. Right, so before we proceed, so I want you to set the stage.
Dr. Pooja is there.
Ma'am, yes. Dr. Pooja, ma'am, she's a professor in neurology. Thank you, ma'am, for being here. She has shown the willingness to mentor both the presentations. She has sat through our warm-up sessions and helped us. Thank you, ma'am, for your presence and being there. She has been an important part of this program. Welcome, Pooja, ma'am.
Thank you.
So with that, before we start the formal presentation and delve into the technical aspects of the presentation, sir, I would want you to set the stage for both the papers together. One, we know that you're a pediatric epileptologist and your primary interest is in epilepsy. I want to ask you, and I have this similar mindset, having been trained by you. Now, I'm looking at one paper, which is on GB syndrome and the second dose of IVIG in a treatment-resistant GB syndrome. There is a second paper, which is on PREVENT trial. It is a core pediatric epilepsy paper. So how would you like to set the stage or look at these papers and what is it that you would want us to take home? In the beginning, I would want to ask you, and then we will start the presentations.
Yeah, thank you, Jyotsna, for that interesting question. It actually makes me think. So the thing here is we all work at multiple layers. We work as clinical practitioners. Some of us are academicians. Some of them are core researchers. or we do all these things together. And then we have our own interest also. So when we look at an article, see what I do, I do, I can discuss. See, one thing is we all know that we have different types of article available. There are randomized controlled trials, original articles, case reports, then consensus statements, so many things. So why we want a journal article is the first question. So the one thing is it's a kind of recent information. So recent information which is coming in print. Anything in print, we try to believe that. So a case report which is in print has got more authenticity compared to somebody telling an anecdotal report, because this has been peer reviewed. So that is one thing. When we go into the other aspects of the story, when you have an randomized controlled trial, which is in my area of interest, I know if it is in a pediatric epileptology, what I would like to look at it is how it is reflecting the current practice and whether there is, I will be more critical in that, because that is very, very clear, because I have the knowledge base in this. So I will be putting that article in perspective into the current literature, and then I will be more critical. And if it is a consensus document coming in my area of interest, I'll be much more critical to see what is the meta-analysis, what is the current evidence, how much is that consensus in that, how much is the hard evidence in that, any kind of guideline. So that is one message I would like to give the audience is any kind of guidelines or anything which you are coming in, you look at what kind of methodology they are looking at. So when it is coming to a GBS, which I am a clinical pediatric neurologist, which is not I am not following that every now and then. So my interest in that will be a typical person with an adult learning kind of a thing. What I can take from that article, what it is actually helping me in my clinical practice in the next patient, which I say, it's like Saraswati started off. So that is the most important thing which I would like to look at, not as a researcher, whether it is actually reflecting the current knowledge, nothing like that. But if it is a little older article, I will be really looking at whether there will be any new changes which has happened recently. So I hope that with all these things, with both Shivam and our Kaushik there, they will be able to satisfy our multiple layers here, and then take us to a kind of, we will come back, or we will get something out of this. We will be a better clinical neurologist after this session with these two different topics. I think I will stop there. I can go on and on. Thank you.
Thank you,
Thank you,
sir.
sir.
Shivam, can you please start?
So good morning, respected faculty and my dear colleagues. I'm Dr. Shivam, Senior Resident from Department of Neurology, AIMS, New Delhi, and I'm going to present the first journal club for today, in which we are going to discuss whether a second intravenous immunoglobulin dose in patients with Guillain-Barré syndrome with poor prognosis does it clearly help. So it was a double-blind, randomized, placebo-controlled trial that was conducted in that was published in year 2021 in Lancet Neurology and was conducted between 2010 to 2018 in Netherlands. And this was conducted across 56 participating centers. So if we talk about why are we having this discussion today? As we know, the incidence of GBS worldwide is around 0.8 to 1.9 per million population worldwide. And we have a current standard of treatment that is IVIG or plasma exchange. But despite giving intravenous immunoglobulins, it has been reported from previous various literatures that 20% of the patients are unable to walk unaided at 6 months. 20 to 30% of them require mechanical ventilation. And there's also associated 3 to 7% mortality. So the hypothesis which the researchers have in mind while framing this research question was whether an early additional immunotherapy in the form of a second intravenous immunoglobulin that may help before irreversible axonal damage already sets in. So why do we consider a second IVIG dose? What's the rationale? So we have seen that nearly 10% of the patients have treatment-related fluctuations, which responds to a second intravenous immunoglobulin dose. There also have been previous studies which has found that a blunted rise in serum immunoglobulin following an IVIG, it has correlated with poor prognosis. So whether giving a second IVIG will increase the serum immunoglobulin levels and help us in a better prognosis. We don't have any randomized trials on that, but there were previous observational studies which have shown that a blunted rise was associated with poor prognosis. And in practice, 25% of non-improving patients are retreated with second IVIG, but there's no strong evidence to support that. And definitely it raises concerns because IVIG is a costly medication, and there's also some serious adverse effects which can happen with the second dose of IVIG. So this was the rationale of conducting this study. If you look at the previous literature we have from India of the second IVIG dose, the evidence has been limited only to a few case reports which has been published, wherein they have shown improvement. There are only 2 case reports regarding that, but there's no further evidence from India to support this. So if you look at the methods, this was the inclusion criteria. So in which they included patients with diagnosed GBS patients, and there was an indication to start IVIG as per the treating neurologist, which is usually if a patient is unable to walk unaided for more than 10 meters, that is grade 3 to 5 of GBS disability scale. And the onset of symptoms should have to be less than 2 weeks. So this was a criteria so that the patient can be included in this study. And to give the patient a second IVIG, that is to be randomized further, the patient has to see the first IVIG within 2 weeks in a full dose in appropriate time, which we discussed previously. But most important was the patient has a modified Erasmus GBS outcome scale of 6 to 12 at day 7, which correlates with poor prognosis. So that they have included only those patients with poor prognosis at day 7, and they have randomized those. So just to revise, what is this modified Erasmus GBS outcome scale? So this scale consists of is calculated using 3 variables, which is age in years, preceding diarrhea before the onset of the symptoms, and an MRC sum score that is 1 week after the inclusion, which takes into account the muscle powers at deltoid, biceps, and wrist plexus, along with iliopsoas, quadriceps, and tibial, it's anterior. So each of them is scored out of 5 as we use a normal scoring of the power, and then we calculate a score based on these variables, and that ranges from 0 to 12. And a score of 6 to 12 has been known to predict a poor prognosis at day 7, with a nearly sensitivity and specificity ranging around 80%. So the exclusion criteria for this study, again, to be to be excluded from the GBS study, any patient who is less than 12 years, any patient who is pregnant, breastfeeding, if you're contemplating any alternate diagnosis, if you the patient is having any concurrent diseases like malignancy, cardiovascular disease, AIDS, or COPD, they were unable to follow up at 6 months, they were excluded. And what were the relative contraindications for the second IVIG dose? Would have been a patient who had a severe kidney dysfunction after the first IVIG dose, or there are pre-existing risk factors which predisposes him for a thromboembolic complication. So these were the inclusion and the exclusion criteria. Next is what was the randomization and masking. So they have used a web-based computer-generated random number sequences that was generated from an external source. The randomization was done into 1:1 manner. It was a block randomization in which they have included 6 patients per block, and they were stratified as per the treating hospital. There were 56 centers, so they were stratified as per the treating hospital. The purpose of using this block randomization is that they want to do an interim analysis, and they don't want one arm with more patients when they're doing that and one arm with less patients. So that block randomization helps in nearly equal distribution of patients in both arms. And this was a placebo-controlled trial. So they have used albumin, which was volume matched to IVIG. And the reason for using albumin was simple because it appears similar in appearance to IVIG, and it's also protein containing, it's also slight foaming. So blinding was done using aluminum foils. The infusion bags were concealed with aluminum foils with opaque lines. And if you look at the patients, the outcome assessors, monitors, and the steering committee was blinded. So this was a double-blinded study. Again, I'll just try to explain what is like when we're doing a double-blinded study. So the participants, there are 3 groups which can be blinded. First is a participant for the first group. The second group is the investigators or the treating clinicians or the outcome assessors. These are the second group. So it appears they have not explicitly stated whether the treating clinicians were blinded. They have written outcome assessors or healthcare providers were blinded. We are not sure whether the treating physicians were blinded. And the third group in the blinding is usually the data analysts. So again, that is not explicitly stated that they were not blinded or unblinded. The more appropriate way, what they have used is actually stating who were not blinded. They have stated that the DSNP board who has carried out the interim analysis were unblinded, and even the data analyst might have been unblinded after the databases were locked. So that is one thing that might be the reason why we are calling it as a double-blinded study and not a triple-blinded study. And obviously, if we have all the three, triple blinding is obviously has a better internal validity as compared to a double-blinded study. So this is a participating.
So, Shivam, in the previous slides, you have a block randomization of 6. So what with the block randomization of 6 patients per block, what is the maximum difference in the number of patients that you can get in each group?
So
it is generally half of the block size.
Blocks.
It is generally half of the block size. So generally, if you have a block of 6, then you're likely to get a difference in the two
3
groups
patients.
of half of the block size. Yeah.
Yes.
Carry on.
So this is the study design. So it was a phase 3 double-blinded randomized placebo-controlled trial. The population was adults more than 12 years of age with GBS and predicted poor outcome. That is modified Erasmus GBS outcome scale, a score of 6 to 12. Intervention was second intravenous immunoglobulin dose at 2 gram per kg over 5 days. The control population was receiving placebo, that was albumin, in similar volume over 5 days. Outcome was GBS disability score, and that was assessed at 4 weeks. So if you look at the study design, and this again, the first day the patient reported with GBS, that has to be within 2 weeks. So it was included on day 1. And then IVIG was started as soon as possible. They've not specified what time the IVIG was started after inclusion, but then they have checked the modified Erasmus score, Erasmus GBS outcome score at day 7, and that ranges from 8 to that day ranges from 8 to 9. And if the score was between 6 to 12, that is a poor prognostic score. The patients were randomized either to a second IVIG course or a placebo course. And the primary outcome was assessed at 4 weeks, but there were multiple secondary outcomes, and that was assessed at 8 weeks, 12 weeks, and up to 20 weeks, 26 weeks as well. So this is other things they have done at the diagnosis itself. They have evaluated for various laboratory and biomarkers, including antiganglioside antibodies wherever possible, infectious serologies, and serum immunoglobulin and albumin levels. So they've also, if needed, they've also done NCS to confirm the diagnosis, and that has been evaluated by 2 separate electrophysiologists. And then also they have used the standard care has been provided to all the patients. So the primary outcome in this study was GBS disability score at 4 weeks that we already discussed, and the secondary outcomes were GBS disability score at 8 weeks, 12 weeks, and 20 weeks, 26 weeks, and then other scores also MRC sum score, overall neuropathy limitation scale, need for mechanical ventilation, what's the duration of mechanical ventilation, the mortality, treatment-related fluctuations, and serial serum immunoglobulin concentrations that were measured. So this is what is included in the GBS disability scale. If the scale it ranges from 0 to 6, and if the scale is 1, minor symptoms and patient is capable of running. In a scale of 2, he is able to walk more than 10 meters or more without assistance, but he is unable to run. If its score of 3, is able to walk 10 meters across an open space with help. 4 is bedridden, 5 needs assisted ventilation, and 6 is dead. So, and the safety outcomes were adverse events and serious adverse events that were reported as per the guidelines and at every follow-up. And this trial was funded study. It was funded by the Princess Beeswax Funds and Sanquin Plasma Products, but they did not have any role in study design. They do not have any role in data collection, data analysis, data interpretation, or writing of this report. So if you look at the statistical analysis method, how was the sample size calculated? So they have assumed that there would be a 20% absolute difference in patients improving by more than 1 grade in a GBS disability scale at 4 weeks. And based on the 20% absolute difference, they have calculated the sample size of 145 patients using a false positive error of 0.05, which is alpha as we donate here, and power of 80%. And then if we use, because this is a binary outcome, the sample size was calculated for the binary outcome. That is an improvement by more than 1 grade. But then they were planning to use the scale itself, the 0 to 6. So it can be either from 0, 1, 2, 3, 4, 5, or 6, any number. So that is an ordinal outcome. So they have, for that ordinal outcome, we can actually reduce the sample size to get the similar power, which they have used 40 to 50% reduction. And then they have come to a 73 to 88 patients, they have come, that sample size was calculated.
So the sample size calculation, can you tell a little bit more? So is it different for ordinal and continuous variables? How does it?
there's some drawbacks of this sample size calculation. So when we calculate a sample size for any study, there are three methods we can do. Either we can calculate it from a pilot study, which was conducted previously on the same design, or when we calculate a sample size, we can use some literature from previous studies estimate to calculate this absolute difference which they're calculating, or it can be based on assumption. So what they have used is based on assumption. That is, there should be a 20, but there would be a 20% absolute difference. That was an assumption. But even using that assumption, they need to give us the proportion of patients in the control group who would be able to who would be improving by more than 1 grade. So if we get that proportion of patients in the control group, then using the 20% difference, we can calculate the proportion of the patients in the intervention group. So we need some proportion of patients. So that's one of the limitation of the study, that we don't have the what proportion of patients they have used. So they have assumed, which is still okay, but they don't have given the proportion of the patients in the control group who will be improving by more than 1 grade to come to this 145 patients. So that's what we can discuss even later also in critical appraisal. So this is a statistical analysis. So primary analysis, it was done using modified intention to treat analysis. So there are three ways of analyzing an RCT, as we all know. Either it's a complete intention to treat or a modified intention to treat, and second will be a per protocol analysis. So per protocol analysis includes the patients who has completely adhered to the protocol, and that only are basically being analyzed. But in the intention to treat analysis, we are analyzing patients in the arm in which they were randomized. So that maintains, the randomization. That is important. So intention to treat analysis, it maintains the randomization. In a modified intention to treat analysis, we are not including all the patients who were randomized for some pre-specified reason, which is specified in the study. Either they have not received the allocated drug, or they were withdrawn from the before the primary outcome would be analyzed. So that was specified in the protocol itself. So that's done a modified intention to treat analysis, which includes some attrition bias, but that is still okay, a method for modified intention to treat. Then primary outcome was assessed using a proportional odds regression, which is a method for analysis of a outcome which is a ordinal variable. And they have done, as I told, they have done a covariate adjustment pre-specified. They have adjusted the final outcome for age, preceding diarrhea, and baseline MRC sum score. These three variables they have pre-specified, and these are also the components of the MRC sum score. The modified Erasmus GBS outcome score. So this is the three other components. So they have pre-specifiedly adjusted for those. And effect measure, they have used an adjusted common effect measure was an adjusted common odds ratio with 95% confidence interval. And the two-sided p-value of less than 0.05 was considered significant. So if we look at this was a trial profile. So they have included uh, they have they have included 339 patients who were assessed for eligibility, and 12 were excluded because some of them did not consent or some of them did not meet the inclusion criteria. And finally, in the 327 patients that were included, 112 patients were found to have poor prognosis as per the modified Erasmus GBS outcome scale. And then 13 of them were again excluded because 2 did not meet the inclusion criteria, 6 declined to participate, and finally 99 were randomized. So 53 in the intervention arm, which was a second intravenous immunoglobulin, and 46 in the placebo arm. And then finally, 49 were analyzed in the second intravenous immunoglobulin arm. 4 was not analyzed because, as I told, it was a modified intention to treat. One who did not, for one patient who, for him the primary endpoint was not available, was not analyzed. 1 did not receive the allocated treatment, and 2 declined to participate before the start of the allocated treatment. Hence, it was MITT. And so out of 53, 49 were analyzed in the second intravenous immunoglobulin arm, and out of 46, only 44 were analyzed in the modified intention to treat arm, but they reached a targeted sample size which they have calculated. So if you look at the results.
So Shivam, sorry to interrupt. So now do you think that doing modified intention to treat rather than a complete intention to treat is a limitation in this study?
That is one of the limitation. Obviously, a complete intention to treat analysis would have been the preferred one. But they have done a MITT as a primary outcome. But if you look at even the complete, which we'll discuss in the results, the complete intention to treat analysis, the results are almost similar to the modified ITT. But leaving that apart, complete ITT would was always a preferred one to perform.
Yes, thank you.
So if you look at this,
Shivam, you have to be clear here. See why that will become a very important thing in a intention to treat. See in which kind of outcomes, if you have better, say, which will be the limitation. So you got it. What kind of result you are expecting here? if you are using a per protocol versus a modified intention to treat or to intention to treat.
So if in the patient, like in the chart that they have shown, if sorry this. So if they are excluding patients that before this one, the others are still accepted, like the appropriate things, one those do not receive the allocated treatment. But if in a intention to treat, if they're including a loss to follow before the primary endpoint, this might be a patient who had a good outcome or a poor outcome, who has been excluded from the analysis. So we are not sure whether this patient has died, whether this patient has a poor, or whether this patient had a good outcome, which would obviously influence the later results.
Yeah, so that will be important if you have a positive outcome. See, if you have a positive outcome, and then you are using a modified intention to treat, and if it is an intention to treat, there is a more chance that it is not by chance. Intention to treat is always the chance is less for the intervention.
Yes.
Okay. So if you go from modified intention to treat to modified intention to treat to per protocol, the chance for a success for an intervention actually is less. So you are making the intervention less privileged by an intention to treat analysis.
Yes.
Okay.
So coming to the results, if you look at the baseline characteristics, there were some imbalances noticed in the baseline characteristics at the though this being a randomized trial, but if you look the age, they were slightly more in the second intravenous immunoglobulin arm. Preceding diarrhea was also more in the second intravenous immunoglobulin arm. So there and the MRC sum score was lower in the second intravenous immunoglobulin arm. So there were some baseline imbalances that has been noticed in the baseline characteristics. And this was a primary outcome, the result of the primary outcome, in which they have shown that the disability score at 4 weeks, both in the second and the placebo group, were around 4, with an adjusted common odds ratio of 1.4 and a confidence interval of 0.6 to 3.3. So this is not a significant result. And the secondary outcomes also, which they have analyzed and which you already discussed what they were checking, this also has not shown in any of the secondary outcome has not shown to be significant. Whether it be disability scores at 8, 12, or 26 weeks, whether it be it the mechanical ventilation. So if we look at this similarly, that is a visual representation of the primary outcome itself. Most of the patients, they have been, they have been grouped in the group score of TVS disability score of 4 and 5, and there's been no much difference between the two groups, one who received second versus the one who received the intravenous immunoglobulin. And they have done a pre-specified subgroup analysis, obviously to adjust for the baseline variables like the age, MRC sum score, the antibodies, and what the nerve conduction sub-study show, whether it's for demyelinating or axonal. So just a quick review, what we are seeing here is a subgroup analysis plot that we are seeing here. The solid line, the vertical solid line, it is drafted at 1, which is a line of no effect. And that then what we got from our common adjusted odds ratio was 1.4. So the dotted vertical line here is plotted at 1.4. So which is again the line of treatment effect from our study that we have. These are the point estimates, and that are dotted at that is squares, and the size of these is represented by it's indicated by the number of patients in each subgroup that we had. And then the horizontal lines, they represent the confidence interval. So we are seeing there's overlapping confidence intervals. And so even in any of the subgroup analysis, the results were not significant. So they have shown that in the subgroup analysis, whether in the primary outcome or whether it was intention to treat, whether it was modified intention to treat, there was no significant effect. So the results have been consistent across subgroup, across secondary outcomes, across primary outcomes using intention to treat or a full intention to treat or modified intention to treat. And then coming to the safety measures which we have taken and the serious adverse events. So if you look at any serious adverse events, they were definitely more in the second intravenous globulin arm, which was 51% compared to 23% in the placebo. And they had more incidence of pulmonary embolism, radial artery thrombosis, transient ischemic attacks in the second intravenous immunoglobulin arms. There were also 4 deaths in the study, and that was all in the patients in the second intravenous immunoglobulin arm, though they occurred at some later time points, that is at around 16 weeks, 14 weeks, but they were all in the second intravenous immunoglobulin arm. 2 deaths were because of cardiac asystole, and 2 deaths were because of withdrawal of life support on request. So, but though they have written that's probably unrelated, but definitely the thromboembolic complications has been found more in the arm who has received the second intravenous immunoglobulin. So coming to the discussion quickly, that is, so they have shown that primary outcome in disability with the second intravenous immunoglobulin in patients with predicted poor outcome after first dose of IVIG has not shown any improvement. And there was no benefit even at later time endpoints, and results have been consistent across the outcome measures. So if we um, so why did this additional IVIG fail? Did we miss the therapeutic window? Was that the reason? So IVIG, as we know, is more effective early in the disease course. And by the time second intravenous immunoglobulin has been initiated, axonal damage may already have been irreversible. Again, a point to bring here is we don't know when was the time of the starting of the first IVIG. That was a very important question because the earlier we treat, there have been various previous studies recently published last year also from Korea, that the time to start of the first IVIG predicts the outcome. So we don't know when was the first IVIG initiated. It was initiated within 2 weeks, but in that 2 weeks, whether it was in the first week, whether it was in the first 3 days, or whether it was in the first 8 days, we do not show. So IVIG is likely most effective early in the disease, and by the time they may have started the second IVIG, axonal damage may already have been reversible. So, and also one hypothesis which we were testing previously was a poor rise in immunoglobulin with a poor prognosis. But then this poor rise in immunoglobulin may itself be a marker of a severe disease and a more rapid immunoglobulin catabolism, and not a modifiable therapeutic effect, as we thought giving a second dose would increase the immunoglobulin levels and predict a good outcome. So this is, therefore, they may say that a poor rise in IVIG is not a modifiable therapeutic effect that we were contemplating from previous observation studies. And
Would you
Yes,
like to comment on the previous
yeah.
study? What do you mean by IVIG is more likely to be effective in the initial part? There are previous studies. What is the literature saying about that?
Yeah,
so there
Dr.
was this
Suman,
study.
can you go to the previous slide? Yeah. Here, actually, one
Sorry.
important point is like the on time to initiate IVIG is very important because only inclusion criteria it is mentioned that it is up to 2 weeks. But in our clinical practice also, we see a lot of patients who present within 48 hours with power zero, and few patients they have a progressive kind of weakness lasting for 10, 12 days. And like we see also that those patients who present within 48 hours with power zero, they have a like worse outcome kind of thing. So most probably in interpreting the result of this paper that with additional IVIG there is no improvement, most probably those group of patients who actually has catastrophic disease were actually classified as severe illness and they were given second dose of IVIG. So yes, if information regarding initiation of IVIG in the control versus the placebo group, then it would be more informative for the in the paper, I think.
Yes, I completely agree on that, and that has one of been the limitations.
Yeah,
As to
Shivam,
answering
you
what
can go
doctors.
on and then we will discuss because
Yes, sir.
that will be, we can have a
Yes, so,
discussion.
yes, sir. So, and then there were some safety concerns. Why did this harm increased? Like there were more side effects. The most serious adverse event second intravenous immunoglobulin. Obviously, there are multiple possible mechanisms. These patients were more ill. These patients have dose-dependent increase in plasma viscosity, immobility, dehydration, inflammation. But we can't just explain that this by solely the immunoglobulin levels. So, now coming to the second part of this general club, that is a critical appraisal. So we will be covering that under these 4 headings. First will be the assessing the internal validity or doing a validity assessment. So how robust were the results within the trial itself? That is what we are trying to answer. So to answer this question, we need a lot of questions that we have to answer. So how was the trial protocol designed? Was there a clearly focused research question? Was any bias? So we'll be discussing under these following headings. So did this study ask a clearly focused research question? So to answer this question, if in this research question, we should have every component of the P code format that we discussed previously. So they did have mentioned the population, that is the GB syndrome with predicted poor outcome. They have mentioned the intervention, which was the second course of IVIG. They have mentioned the control arm, that is a placebo, and also the GBS, the outcome will be a GBS disability scale, and the timing was 4 weeks. So this a good question has all these components of the P code that we already discussed. And a good trial also publishes a protocol. They did have published a protocol of into around 2018, and they have almost adhered to what they have specified in that protocol. They have not shifted from the protocol. And so at this point, we have already discussed so what the statistical method which they have used for analysis, that was a modified intention to treat approach, with the biases it can cause. This point already has been discussed. And again, the randomization, a good trial, there should be a web-based randomization. That is a good way of randomizing. And then also once the patients are randomized, the investigators should not know like the next patient will be going in which group. Like if they already know the next patient which will be going in which group, they can obviously decrease the power of the study. So that is known as allocation concealment. So yes, the allocation was concealed because it was a central computer-based web-based generator that was generating the number. And after the number was generated, the drug medication was distributed in 4 trial boxes, and therefore the investigator was not aware the next patient will be going into which of the following groups. So the randomization allocation was concealed. And then if we look at the baseline prognostic variables, were they balanced between the two groups? We already
Different things.
discussed that.
So, Shivam,
Yes, ma'am.
so these are two different things. So, the randomization and the allocation. So the allocation was concealed is different from randomization. So I don't think that you should write it together. So it is allocation concealment, that how they were actually told that they are going to be in what group. So that allocation, a randomization was computer generated, and also because it was a computer generated process, and the way they were handed over the drugs, so that made it concealed. So it is different process. Randomization being concealed and the allocation being concealed are two different things.
Yes.
Yeah, Shivam, you can make it a little clearer for people. What will happen if there is a kind of a breach in this?
So if like sometimes what we use is like one method is using transparent envelopes and writing the numbers on that. So if the investigator who is doing this process of like once a patient is randomized, and if the investigator already knows to which arm the next patient will be going, the next arm if the patient will be going into the intervention or the control arm, he may not randomize that patient only if he knows that this patient has a poor prognosis and he might go into an intervention arm. The investigator may think of just excluding that patient from the analysis. So that is one, like if the investigator is already aware that to what next arm the patient is about to go, then they will be excluded from the analysis. That is
No,
what
how
we are
it
going
will
to.
how it will affect the results. That is what I want.
So yes, so if they're excluded, if he knows that this patient is going into an intervention arm, the investigator may not at all try to include that patient into the study itself. The patient might not, the poor patients, the patients with poor prognosis will not be included in the study itself, and they all may be going into the control arm. So that is what we are trying to convey.
No, not that only. See, there are two issues here. One is the investigator, the primary investigator, he has got an interest in the product and he wanted to influence the result. What you are telling is right. But what is happened in the other way around is if you have a study site, another study site, what will happen is patients with bad disease will go to the intervention. It will not go to the placebo. Okay, not the other way around. Because you know that as a clinician, I will try to give the IVIG to the patient, not the. So it depends on his perception.
Yeah.
Okay.
The study design, what they're trying to
No,
investigate.
not study design. It is the perception, because I want to give the medicine to the patient. So you know that the next patient is going to get the placebo. You will not randomize. You ask the patient to buy it from outside, or you put it in the other thing. You will not put it in the investigation thing. Okay.
Yes.
So that will affect that bad patients may go into the study site, not the control site. Because the clinician wants to give that intervention to the patient, not the placebo.
Yes, sir. So that in this study that is what, yes, sir. I agree on that.
Yeah, that is also possible. See, when you have an intervention, we want to give that intervention, benefits of that intervention as a clinician, not the investigator. Primary investigator has got a bias for the product. He will not give it to this thing because he is worried that it will affect the outcome. But most of the time, the other investigators will try to give the intervention to this thing, and then he'll end up like the investigator side or the study arm will have more difficult patients, and the placebo arm will have a less difficult patients, and that will affect the effect size.
Yes.
Okay.
And also, if the randomization was done properly, but the person knows that in randomization which group the patient is allocated. So if they are allocated in the arm which is receiving the intervention, and the investigator is biased towards making the intervention more effective, they are going to give more attention to the patient for them getting better results, whereas the placebo person might not get same attention or the same in the level of attention and the level of follow-ups, all those things may be less. So falsely making the intervention look more beautiful than the placebo. So that is why, as important is the randomization being blind, it is very important that the allocation be concealed.
Okay, so that's for the people who are attending, because this is, even though all the things are very right on paper, on the site, these kind of things can happen, and either it will bias towards the study or it will work against the intervention. Both can occur. Okay, go on.
So the baseline variables are prognostic variables, which we already discussed. There were some variables which are, there were relevant imbalances noted at baseline in age, preceding diarrhea, and MRC sum score, which are all influence the outcome, but they have done a pre-specified covariate adjustment for that, and therefore they have calculated this adjusted common odds ratio. So that has shown to be non-significant, but there's some other limitations, is like what baseline variables have not been reported. One we have already discussed was time from symptom onset to IVIG initiation, which could very well like influence the results. And also there's any presence of autonomic dysfunction, which has also been implicated as one of the prognostic variables in patients with GB syndrome. So now coming to the next question, again, this we have already discussed was the patients. So it should be an ideal study, should be a triple blinded study in which the patients, the outcome assessors or the investigators and the data analysts should be blinded. So in this, they have clearly stated that the patients, the healthcare providers, the adjudicators, the outcome assessors, they were blinded. But who were not blinded, that is important to know, is the either the pharmacist who was distributing this trial medication, and also the interim analysis committee, that was a data safety and monitoring board, for which they have to unblind the results. So therefore it's not so it's the wordings may vary, but we should know who were not blinded. And since everyone was not blinded, it's a double blinded and not a triple blinded study. Next.
Shivam, going back to your previous slide, so there were some baseline imbalances. So I'd like to know from Vinay and Saroj, is there any way which we could, if the study was done differently, is there any way this baseline imbalances would not have creeped in?
These.
Yeah, Shivam, you say that.
So this baseline imbalances, if they could have randomized based on the age, that is one way, or the preceding diarrhea, they could have the randomization could have been stratified based on these variables itself. That is one way to avoid this baseline imbalances. But then in a randomized trial, it is expected that there will be no baseline imbalances, and therefore it is usually p-values of these baseline variables is usually not given. That is that is an accepted thing in a randomized control trial, not to give a p-values of these baseline variables, because we are hoping that in a randomized trial, both the sites will be balanced. But when the sample sizes are small, this issue crops up in then that there's some baseline imbalances. But in this study, because they were expecting a small sample size from start, it would have not been wrong if they could have stratified as per these baseline variables also.
See, one thing is, it is better that the best thing is what, Shivam, here. You have a large sample size and then there is no adjustments. Okay, so that is the best study. You have seen the stroke studies where they take thousands of patients, and then when you have multiple factors which can affect the outcome, which can affect the clinical course. So the best thing is the large numbers, which will, and then you do a multiple ways of regression analysis and then look at the outcomes, which way this is going. The moment you start adjusting from the beginning, there is always a chance, and there is no ideal way, and there is no ideal study in that sense. So we can criticize this article, but there is always, when you have lesser numbers, you have to have a balance in the beginning, so that there is no way out. So this balance is, say, possible if you have larger numbers and then if you have balanced better. But again, then there will be some imbalance in the other numbers. Or the best will be a multi-centric large study with 1000 GBS or 2000 GBS. It would have been better in this kind of a study.
So that is one of, again, the drawback of the study. In 8 years, they have recruited only 336 GBS patients and from 56 participating centers in Netherlands. And if you look, most of the patients' papers from GBS are from Netherlands, previously Erasmus. and all they're from Netherlands. So this is one again of the drawback, like how could they recruit so less patients in around a span of 8 years from 56 participating centers? And that to 44% of the patients, including in this study, are randomized for one center out of those 56
So why,
centers.
what is your explanation for that, Shivam?
So that is like again a center-based bias. That's like one center is only recruiting.
No,
That
why
is one.
people are not, why there is no recruitment failure or recruitment delay? What are the causes of recruitment delay in an RCT?
If the like if the other centers are not as well versed or as well to do as compared to the primary center who has initiated the trial, and then if there's difficulty in procuring the treatment drugs, if they're all referral centers, if they are primary or secondary centers with no good mechanical ventilation, good ICU care, and maybe they might be the referral centers. That is another
So
reason.
that is one of the main reasons. Many times this fails in pediatrics. So that is, what is it? See, the lack of consent. When you have a bad disease, who is willing to give you? If one of our relatives are there, and then who is having a bad GPS, and will you be willing to give a consent for a placebo control trial? That is the usual thing. There will be a recruitment delay when you have a bad disease and you are comparing an intervention with a placebo. The families may not agree for that. That's the one major thing. And then what happens is only the primary center who has got a real interest in the study, they will recruit more. The others they will not recruit, they will not recruit, or they recruit very less, because you need lot of communication, lot of interaction with the family to go for a placebo controlled study. That is the real issue in this. When you have a bad disease and when you have an intervention compared with placebo, this happens in all over the world.
Yes.
Okay.
And the same group has also published a ICID study. This is a CID GBS you are presenting. ICID was a non-randomized observational study. So even there, if we see, they have excluded patients who were in ICID from CID, but there also there were only 38 patients or so who received second course of IVIG. So probably, like Sir said, the number of patients who participated very less. Despite having two separate studies, one observational and one randomized, the numbers are less.
Yeah, that is well known. See, when you have a bad study based on an ICU setting, where you have a placebo arm there, the families giving consent to that is very, very less. And the ethical controls are also very, very strong at that sense. You might have to have a lot of ethics regulations in doing this study. So then the recruitment will become delayed and it will affect the outcome, the number of patients, and then this thing. The recruitment itself gets affected here, not the follow-up. Okay, go on.
Next question, like for assessment of internal validities, was a clear rationale for sample size calculation. This we have already discussed. The clinically, that was an assumption of 20% more improvement in patients with second IVIG group as compared to the placebo group. And then we don't have the control rate, control numbers, proportion of patients in the control who will be having a good outcome. So that was one of the limitations already discussed previously. So assumed baseline walking rate used for the initial sample size calculation was not explicitly reported, making the derivation 145 non-transparent. Now coming, what are the results? The second, after the internal validity, we look what are the results and how precise are the results. So the effect estimate was given by odds ratio, which and then and for the precision, we need to look for the 95% confidence interval and the p-value. So if you look at this the confidence interval 0.6 to 3.3, which is a very wide interval crossing one, and then the p-value is also more than 0.5, which is not significant. So for the estimate lacks a precision. And one of the important reason for this lack of precision is a limited sample size that's affected by these wider confidence interval. And
okay,
coming,
Shivam, we'll stop here. This is basically, we don't know. Now this study now clearly says that if we had a larger number of patients, whether we could have reached that. Okay. So that is the difficulty now. Here it is, when we are discussing this, we have to be clearly telling this, because there is a very strong bias against the intervention because of the limited sample size. Okay.
yes, sir.
Okay.
So coming to the how are these results applicable outside the trial setting as well? That is external validity. So the applicability assessment, if we compare the populations of this group compared to our Indian group, that is a Dutch group versus the Indian group, Our population is slightly more younger. They are like the incidence of demyelinating disease in the Dutch population was 63 to 66%, but in our population is 54% nearly. And in the Dutch population, they obviously have a uniform IVIG access. They have more standard ICU, first day ICU cares, but we have limited ICU cares, limited IVIG access. So they were not entirely similar to a population. But then this this intervention is definitely relevant in our practice for the reason being, if we are saying that this second IVIG is not benefit, we don't unnecessarily need to push the patient to buy a second IVIG, which is even the first one he's finding a difficulty to afford. So there's a lack of demonstrated benefit and cost constraints and safety concerns. So it's relevant in routine Indian practice not to push the patient to buy a second IVIG. But then the study didn't come up without limitations. One being the small sample size with a wider confidence interval, which we already discussed, and then the long recruitment period, again, which we already discussed, and some baseline imbalances that were there. But that limitations that have not been acknowledged by the authors is potential misclassification of prognosis, meaning to say they were prognosticated after the first IVIG, like within 2 to 3 days itself. But the IVIG action we have found from the previous studies may start from few days, but the effect might come after 2 weeks or 3 weeks. So that was it too early to misclassify them as poor prognostic patient? And then we have not, again, heterogenetically of the GBA subtypes, like the demyelinating or the axonal has not been clearly stratified. And for primary endpoints, they have taken a large effect size of, they have large difference, 20%. So it may be insensitive for too small but meaningful gains. So, but then obviously, if you're taking a large effects, 20% difference, the sample size comes out to be small. But if you take these small gains, like a 10% if they have taken, they would have needed a larger sample size. And obviously, the safety signal was underpowered. We can't say that from this study, at least, that the IVIG is associated with more in general thromboembolic complications, because the study was not powered to measure that treatment effect. But obviously, we found some evidence of more thromboembolic complications, but it is still difficult to confirm with surety that this is the reason for that was a second IVIG use. So to conclude, second IVIG did not provide any clinical benefit in GBS patient with poor prognosis as per this study, but there were higher rate of serious adverse effects. Therefore, we need some alternative immunomodulatory approaches beyond IVIG, merit evaluation in GBS. So did we have evidence after this? This was study published in 2021. Then there was a synthesis without meta-analysis. So that was that published in January 2025, in which they have included 10 studies with 94 patients. So in which our randomized trial was also included, but there were others were only observational studies. So they were not equally, they were very heterogeneous studies. They have very heterogeneous results. Therefore, they could not do a proper meta-analysis. They have just done a systematic review without any meta-analysis of observational studies and RRCT, and they've shown that 70% shown motor improvement post second IVIG, and 54 to 50% reported successful ventilator weaning. But most of these observational studies have included patients who were requiring mechanical ventilation. So again, this evidence has to be taken with a pinch of salt, though they are showing that, but this is not a meta-analysis. So and then after this, do we have?
Shivam, what is the issue with this kind of a thing? What bias will come when you include case series, case studies? What bias will come?
So the best evidence comes from meta-analysis, then the second best evidence comes from RCTs. And then if you look at the observational studies and the case studies and case series.
So what I was telling is meta-analysis, including which kind of studies? So if you included a lot of case studies and case series, what is the bias there?
So
even in the meta-analysis,
these results, there's a lot of heterogeneity that will be there, and
there is a publication bias. There is a publication bias. Only the positive outcome with cases will be published in the case studies and case series. So there will be a lot of publication bias. So you have to, whenever you see a systematic review or meta-analysis, you have to go through those papers. How many were actual RCTs? How many were having only case series and case studies? Because case series and case studies have got a strong publication bias. Whoever has got a good outcome will get published. If you have a 60% outcome only, you will publish, or 70% outcome only, it's published. So if it is a 30% outcome, usually there will not be an interest from the author to write it. There will be no interest from the journal to publish it. Okay, so there is a very strong publication bias. So whenever we discuss this kind of a study, we have to take that. Okay.
Yes. And then the further evidence which we are coming is like other therapies, other immunomodulated therapies, including monoclonal antibodies targeting C5, targeting C1q, these are still under research. One of the trial, Tanru-Prubat, that was published last year, was positive from Bangladesh, but this is still again undergoing a further trials. So, but these can be questions for future discussions. So the take-home message in this will be in patients with poor prognosis response to first IVIG, the assessment for alternative diagnosis, including nodopathies, acute onset CITPs, or other mimics, should be prioritized rather than just empiric escalation to a second IVIG. And the current evidence does not support routine second IVIG use in poor prognosis and GBS. This is as per even with the strong evidence that is given even by the European Academy of Neurology, peripheral nervous nerve system society. In their guidelines also, they have taking this RCT only into account. They have advised against the use of second course of IVIG. And so this brings us to the last question that is open for the audience. That is, do we need some larger randomized trial to answer this question, or we do have sufficient evidence of second IVIG? So with this, I would like to end the presentation and thank you for patient listening.
So Shivam, I will ask you a question before going to the question. So I am a pediatric neurologist working. I am seeing a next patient with a second dose first order IVIG, patient on ventilator. So what is your advice based on this study for me?
I would not, and with the current evidence, I would not advise going for the second IVIG. If the patient is not improving, it is important to rule out other causes, alternate diagnosis.
That is all there. That is all there. So
But,
whether this study tells you, this study tells you that you should not use.
This study does tell there's no clinical benefit. There's more serious
that is what
adverse
the
effects.
adaptability. What I am showing is the general applicability of this study to my patient, an 8-year-old boy who is coming with GBS. That is one question, no, as a clinician, which I would like to. What is this study giving me?
So this is definitely showing that there's no evidence, but if you want to still use it, like there's something known as an action bias, because we don't have sometimes much to do.
No. See, the thing is, this study is not telling anything, okay, for my patient, because this study is a elderly patient with a very bad. You see that.
Okay.
You cannot tell that conclusion. Also, you have to say that this study showed a GBS in a elderly group of patients.
Yeah, age more than
because
12
you
years.
see the mean age of that patient.
Yes.
So
okay,
elderly group of patients with a poor prognosis GBS. See, elderly group of patients with GBS, what are the major complications compared to a young age? They are already with comorbidities. They are more prone for thrombotic episodes. They are already having a bad prognosis. Okay, so you have a group and then you take it as any patient with GBS. This study is not giving that answer. Okay, so that is the external adaptability. Okay, but we don't know. We don't know at this point. So to the next patient, which I have put in this thing, this study is not giving me that answer.
Definitely for pediatric patients, this trial is not powered, and it was not including also the patients of pediatric population.
No, I am telling you a 30-year-old man now. So you are seeing the next day, 30-year-old man who is otherwise healthy, and he had a GBS. He has been given IVIG, and he is on ventilator now. So you are coming up with, as a resident, you are coming with to the consultant and saying me that this study is showing that no need for IVIG, and then, okay, what will you do? So this study is having that kind of a strong adaptability?
So that's what there were limitations in this study.
That is
we can't take this study as a source
don't
study.
generalize. Don't generalize. Yeah. That is the message. The conclusion was any patient with GBS, poor prognosis GBS, this study is not giving. We don't know whether it is there or not. Okay. Now next question is, I am asking you, a 65-year-old man with multiple comorbidities, already on this thing, you are trying to say that GBS, this study has failed. So an immunomodulatory therapy is the best option for that, because you concluded like that.
So besides IVIG, any other immunomodulatory?
No, you give an IVIG, because that is the adaptability question. As a clinician, I will be interested in that adaptability question in this study. Okay, so the next patient, it will be different. Next study, it will be different. So a 65-year-old man is there. He has got multiple comorbidities, and then he is on ventilator. And then the first IVIG has failed. Okay, So you are trying to say that this patient should go for other immunomodulation. So this study, that will be the right thing from this thing?
No. So this study has included patients with multiple comorbidities. So we don't know in that patient, in that subset of patient with that multiple
we don't know whether
comorbidities.
that
Yes,
will be, the harm is much more than this.
that is.
Because the IVIG here has produced some harm in this group. So whether that group in a bad comorbid immunosuppressed group, whether the other immunomodulation will produce more harm, we have to have better studies here. So don't
Yes, sir.
conclude like that, because that message to the people who are hearing, which we are taking it very simply, the message is they will try in the next patient rituximab straight away. In that kind of a patient, it may not be a right thing from this study. Okay.
So that is not I was trying to say, but then as per the recent guidelines, also the guidelines which we follow, they also have taken, like, given this statement very with a strong evidence that there's no benefit of.
Say,
So,
guidelines
but then we
don't take
definitely
anything.
need.
So, Shivam,
Yeah.
so again, not to you or to everybody, don't take guidelines a very strong thing. Guidelines comes based on this research. So
Yes,
when we are criticizing this research, this article, this original article, this RCT, they based on that, there is no evidence. They are coming with a consensus on top of that. Okay. So don't put guidelines above the RCT. Guidelines are below the RCT. Guidelines are below the meta-analysis. Guidelines, especially a consensus-based guidelines, have got just above case report level. Okay. So you have to go through that guideline, what kind of, it's a hard evidence, what kind of evidence they have given there for this article and whatever articles have given. Don't put after this, say that the guidelines are given like this. So this is guideline is better than this. Okay.
Obviously, I agree on that. We can't just conclude based on this whole trial, and we need further larger studies with the
again,
limitations
guidelines
addressed
are
that
not
we have
above
discussed.
the RCT. Guidelines are
Yes,
not
sir.
above the RCT. Guidelines
Yes,
are
sir.
below the RCT.
Yes,
Okay.
sir.
So
Another point, sir, if the primary outcome was different, sir, so like something like number of days on ventilator. So is our primary outcome good enough? I would like the moderators to come on this and educate us about that.
Jasmine or Pooja, they are better.
So the question is that we could have had different outcome. Is that?
Is the primary outcome
a different outcome?
Is number of days on ventilator, whether the outcome would have been changed? That is the question from.
That could have been, but I think that would further decrease the sample size to only the patients who were on ventilator. So that may further decrease the effect size. So I think I'm not sure if that would have been a better outcome, but if that is to be taken as better outcome, we would need even greater sample size, and the severity would be even further deteriorated. Like our patient population would change to even a worse population than what we are having now. So I think that this is fine to take this out, as primary outcome.
This from my end as a researcher, I just try to point out to the whole thing, the group, is that this highlights the difficulty of doing an RCT in a ICU population, in a bad patient group, because we had lot of studies failed only because the lack of recruitment in neonatal ICU, any PICU, very bad case where you have a placebo-controlled outcome, placebo-controlled study, the overall recruitments fails. That is a part of thing that is accepted. We have to go with this. But this study clearly tells that if you have an elderly patient with multiple comorbidities, the overall outcome, for me, the thing is the overall outcome is not that good. And a second IVIG is not helping to improve that outcome. That is the way I will put this. And that for that, this study is clearly powered to some extent, even though we say that that could have been better.
I think also, whatever outcome has been taken, it has been taken at a very shorter time duration of 4 weeks. So I feel that, the course, the patient having stability for 4 weeks in the graph that we see for GBS, there is a stable period where the patient might stabilize in 4 weeks and then might improve or deteriorate. So, I think if they would have taken a longer time period in the outcome, then maybe the results would have been, maybe they would have been different, like at 3 months or 6 months. So I think the time period is a little shorter. That could be a change that
No, Shivam,
I
that has
could have
been
thought.
tried, no? That is 3 months and 6 months outcomes are
At
there.
6
No?
months outcome is
That
also
was at
there.
secondary. That was secondary
Secondary outcomes
that
are also not shown, no?
not
Shown
shown
benefit.
benefit. Yeah.
I think
But then,
for
as Van
me,
said,
like what could have made a difference is the effect size. It was like 20% change in 20% change in control versus if it was kept at 10%, I think that could have given a positive result, I guess. Otherwise, I don't think any change could have made a difference
what
because only GBS disability score of change of 1 point and case versus control, it was treatment versus placebo almost 20%, capped at 20%. If 10% effect size was 10%, I think it could have been made a change in the result. Otherwise, I don't think
Yeah,
so.
so Jidamam, you want to say that the study trial is biased against the intervention here. That is what you wanted to say? There was a,
I mean, to put it
no,
like
the way you are putting it, it is
Yeah.
something like that.
Yeah,
Because
yeah.
it is the see, it is again, it is again a strong point. See, the trials can be defined or designed to prove a point or to disprove a point. Because if there is a lot of patients who are getting left and right second dose of IVIG in Netherlands, and they can design a study to say that it has to be shown very strong effectiveness, then only it has to be used. Okay, so if that study, so if the study design is something like that, then even minor things will not be shown. So
Yeah.
the study design can be planned positively and negatively. That is again another message.
But
Yeah.
taking that point, sir, it was a funded study. So why would that company who was funding IVIG would not want that patient should receive a second IVIG?
No,
They would
it
have
is
been
something
actually
like,
wanting.
say, you understand the system there. It's a managed care system, a government control system. The government, if you worked in a government control system, they always try to cut costs. Okay. So that will be a very rigorous study. Okay. So the insurance companies will be really strongly for not giving that. So there are a lot of players there. It's not only like India. Okay. There are strong financial things, but this kind of studies, I will not say that there will not be any, because there will be biases coming from multiple ends. So it will be balanced at the end. So this is a very good study in that sense, because the people who have provided that doesn't have any control over that study. That is for sure.
Yes, sir.
And here also, like in effect size, like there are two things, like change in disability score by only 1 point. Change in disability score by only 1 point, but the difference between the treatment and placebo was kept at 20% difference. So a minor change in personal outcome, but the group difference was kept at big size of group difference between treatment and placebo. That I think that made the difference between the control
Yeah,
and
so what is again, Jidabam is highly, see, what he is trying to bring out is the placebo effect in the whole study. Because when you have a bad disease and you are taking it and the disease is going to improve, whatever you give, there will be an improvement in the control arm also. So then the effect size will not come out. The comparison will not come out. If you have only 1 point difference, and then you want a big difference between the control and placebo would have also improved, and the control will, the intervention arm also will improve, means you will not get that comparison. So that is the thing you wanted to show, no? You wanted to tell that.
yes, sir, yes.
Okay. So that is very well known in epilepsy trials, because most of the time the placebo effect is up to the tune of 40%.
Right.
So that means 40% of placebo patients are improving in bad epilepsies in a clinic controlled RCT environment. That shows that there is a natural recovery to some extent. And here GBS, you know that this is a disease which can improve with time. And if the placebo also improves, intervention also improves, we will not get the statistically comparable effect.
Yeah.
The
Right.
GWB care studies on cannabidiol also, placebo effect is as high as 30%, 30 to 40%.
So all epilepsy trials, it is around 30 to 40%. That means 1/3 of patients are improving with placebo in that study. Why? Because you are taking the patient. So you understand the setting here. A patient is going for an intervention when the things are really bad. And from that, there is a chance that patient can improve better, naturally better, both sides. Okay, so the patient goes to a trial when there is or the families decide for a trial when there is no other option. There is no other intervention. So the kind of, if you are not keeping a big difference, like the SMA trial, which has shown that everybody is not dying, then everybody who reached the arm with four patients, with 5 patients, they stop the trial because it is a hard endpoint is reached that easily. So when you have that kind of a hard endpoint, it is very difficult to get in this kind of trials. Okay, anyway, we have to go to the next thing, no? It was a very good discussion. Shivam, you have presented very well.
Thank you, sir. Thank you.
Kaushik?
Yeah, there
We
are some
move
questions here. Block designs and all, some questions are there, no? Before going to that, we can take that. Maybe 5-10 minutes.
And there are some questions in the chat.
Chat box regarding the block randomization, something some people are asking some questions.
Shall I quickly go through that, sir?
That is better.
Yeah.
What is block randomization? Will it not affect the results? Dr. Jasmine, I think you made that point in between.
Yeah, so basically, with the fixed block size, like, in this case, we are taken 6. So generally, the question is that, it may affect the results. I'm not sure. Basically, the thing is that if you know that what is going in that block, like, you know that the first patients have got placebo and then you can predict that the next 3 patients are going to get the drug. So you can predict in that manner. But if the allocation is properly concealed and you have strictly adhered, then the block randomization is not going to cause that selection bias or affect the results. And it is actually going to adjust the numbers well, the number of patients in the control group and the number of patients in the active group. So it is going to control that well. But there is a little risk of selection bias, which if you conceal the randomization properly, that just comes down with that.
All right. I think another question is albumin and inert placebo. What is the effect of active placebo?
So basically, the question is that albumin may act as an active placebo. So I think there is no immunomodulatory effect. There may be some effect of decreasing the inflammation or so, but there is no active immunomodulatory effect of this albumin compared to IVIG. So there may be some effect, but not the immunomodulatory effect. So I think it is fine to have that as a placebo.
Inert placebo. Inert, yes. Albumin is inert at this
No, the
point.
only thing I can think of is if that's a very bad patient, a lot of hypoproteinemia is there, whether they got better because you gave albumin. So you can think widely and then say that, okay, this is already a bad patient group. With that albumin, they got some betterment on that compared to inert placebo. We don't know. But immunomodulatory effect, definitely, it is not. That is the thing which we were looking at. But when you look at the disability, whether the albumin has improved the disability on the placebo side, it is difficult to say.
So there's another one saying effect size decreased during sample size calculation. Sample size became 2 times. I didn't get this question. Can one of you take it? I didn't understand the question. It's very difficult to prove small effects. Sample size became enormously very high, not feasible. If threshold of effect size decreases to get positive results in trial, there is chances that effect became non-meaningful. I think it's a comment rather than a question.
No, that is what we discussed here. Discussed. Because if you have an effect size, if a small effect size, and then you try to get that, you need larger numbers. Okay.
Yes.
So that is the simple way we can put that.
Right. So we'll move on, sir.
Yeah.
Yes.
Yes. Dr. Kaushik,
so
go on.
All the best, Shivam, for your quiz.
Thank you, sir. Thank you.
Okay.
So we are entering the realm of pediatric epilepsy. And Dr. Kaushik, please start.
Yes. So is my audio okay and slides are visible, right?
Yes, yes, yes.
We'll be discussing on one of the most interesting studies which came up in the realm of tuberous sclerosis complex, the PREVENT trial. This was published in the Annals of Neurology in Jan 2024, a recent trial. So which came up with a statement, early treatment with vigabatrin does not decrease focal seizures or improve cognition in tuberous sclerosis complex, the PREVENT trial. So today we'll be discussing why the study came up regarding the methodology. We'll be dissecting the results using consort as well, and what major messages or lessons we have to carry for future is we are going to discuss. So tuberous sclerosis is well-known entity in terms of epilepsy. It's quite common. 80 to 90% epilepsy is there. Most of them are drug refractory seizures. One more interesting entity apart from the epilepsy part is the associated comorbidities, psychiatric comorbidities in terms of autism spectrum disorder, developmental delay, wide spectrum of TAND is ever evolving. Usually every study stems from the results of the previous research. This study also roots from almost 2 decades ago, where people started exploring screening EEG in an asymptomatic tuberous sclerosis infant, whether the EEG can be used as a biomarker to predict the future risk of seizures. And they came up with positive results. There was one study with a very small sample size of 5 subjects, but another one with almost 40. They said that they were able to predict the upcoming seizure with just an EEG, at least by around 3 months before the seizure actually occurred. Now, this gives a very big window of opportunity, which is when we can start treating with medications, anti-seizure medications. So one of the interesting studies came up in 2011, which they applied the concept of preventive anti-seizure medication, vigabatrin. Whenever the EEG showed abnormalities, positive findings, they started on vigabatrin, and they had very significant seizure control, reduced drug refractory epilepsy. In fact, the study came up with a paper 8 years later, a follow-up paper, where they had sustained positive results. Over the next decade, from 2011 to 2024, subsequent studies came up one by one, all with similar results, suggesting some role for vigabatrin as preventive therapy in infants with tuberous sclerosis. That is where our studies, PREVENT trials hypothesis statement is rooting from. So if we introduce vigabatrin as a preventive therapy, after seeing an EEG abnormality, will it improve the developmental outcome at 24 months of age, and will it reduce the risk of drug refractory seizures, is what they are questioning. So this was a very properly planned phase 2B multi-centered randomized double-blinded placebo-controlled trial. 13 tuberous sclerosis clinics across USA. The diagnostic criteria should be fulfilled. Age must be less than 6 months. And one of the important exclusion is that they should not have any seizures, past history of seizure, no EEG abnormalities in the baseline EEG. Again, they should not be on any anti-seizure medication, not on any mTOR inhibitors, and prematurity was also an exclusion factor. So the enrollment happened between 2016 to 2020. As and when the infant is enrolled, they will go into a phase of watchful waiting, which means serial EEGs will keep on happening every 6 weeks in the first year, and in the second year, every 3 months, the EEG will be done. So EEG is done across the 13 centers, right? So there will be a cloud-based EEG platform where the EEG will be directly shared, and there were 2 central EEG readers who had a very good pre-specified inter-rater agreement also, and they were predicting the EEG abnormalities. Once there was any abnormality and no seizures, this is the most important, was the randomization trigger in the study. So there they had a very simple randomization, 1:1 randomization, either they go to vigabatrin or placebo. So let us assume 2 situations. What if even before the EEG abnormality, a child who has been enrolled in the study got a seizure? They will be directly shifted to an open label vigabatrin group. So this is actually, they continue to remain in the study. They will not be excluded, but they will not be randomized. The second situation, they are in the study, enrolled, EEGs are serially being done, but no seizures ever. And the EEG has been normal throughout, so they never get a chance to be randomized. So these children also will be continued till 36 months as comparison groups. So both these groups were actually treated as comparison groups. Unfortunately, they could not be randomized, but they will be a comparison group. Now, after randomization with vigabatrin or placebo, the randomization was of course, the allocation concealment, it was all blinded, where there were identical sachets were made. The vigabatrin starting dose was around 50. It was escalated to 100 milligram per kg per day over 3 days. And who was unblinded is very important. They have clearly mentioned that the lead statistician, the pharmacist at each center, and there was an independent medical monitor who was controlling all the centers. These 3 people were unblinded. Everyone else is blinded. Now, what happens if they throw a seizure, any of these group, if they get into a seizure, they will automatically be started on vigabatrin. So the dose will be escalated to 150 milligram per kg per day over a 2-week transition, blinded transition phase. Now let's go to a scenario B, where they have been randomized, but this seizure never occurred. They were seizure-free till 24 months. Again, at the end of 24 months, that the primary endpoint time, they will be gradually the medication will be discontinued over a 2-week transition phase to a open label vigabatrin. Now, this was done because this study was following a ITT, intention to treat protocol. Whoever randomized will be analyzed irrespective of whatever the consequence happened. So 84 children, infants with tuberous sclerosis were enrolled in the study. The primary outcome parameters were the cognitive parameters, which is the Bailey-3 score and the Vineland-2 adaptive score. It was done at multiple points, but 12 and 24 months of age were the primary outcome parameters. So when you look into the primary outcome parameters, the Bailey and the Vineland, in addition, they had multiple other sub-scores as well. These were all pre-specified primary outcome cognitive parameters, which were measured at 12 months and 24 months. They chose very carefully. They have chosen a repeated measures GLM model. And for this, there are multiple measures to be simultaneously measured. So they have chosen a MANOVA. And 2 parameters were actually adjusted. The gender and age at randomization was adjusted. None of the other baseline characteristics was pre-adjusted. Let's come to the seizure-related parameters. With regard to the seizure-related parameters, they were checking what is the proportion of the participants in both groups who will be developing seizure, who will be developing drug-refractory epilepsy, and what is the epilepsy control status. Now, what we are checking up is a proportion. So they took an ideal test, a chi-square or Fisher-exact for small numbers, and they wanted to show the results in a pictorial representation, a Kaplan-Meier. So they were looking at something called as a hazard ratio. So they have chosen a Cox proportional hazard model for the time to first seizure or time to the first infantile spasm, all these things. And adverse events were also shown in a pictorial format. They were choosing a log rank test. Here, they did not want individual hazard risk. All that they wanted to see is between the groups if there is any significant difference is there or not. So this is log rank is another time to event curve that will just say whether between the 2 groups if there is any significant difference is there or not. That is what they are going to say. There were minor protocol deviations, COVID-related deviations, which I'll mention in the limitations part. So now this is the most interesting aspect, how they derived the sample size for this study. So initially, they assumed the primary outcome parameter is something related to cognitive score. They have taken the data from predefined some studies which were scoring the outcome based on the seizure part. There is a contradiction here, but we will see why there was a contradiction. Previous studies have shown that if you take randomized, if you enroll 40 infants with tuberous sclerosis, 15 such infants may not develop any abnormal EEG or seizure at all, which is close to 40% will not be getting randomized at all. So they had a necessity to over-enroll. So they assumed a model-based assumption was made. They raised a question, if we randomize 20 to 25 infants per group, so vigabatrin group and placebo group, if they randomize 20 to 25 in each group, and let's assume the seizure rate occurrence is different between the 2 groups, are we going to have adequate power is the question that they asked at this point. Now, this 48 number was not a very derived variable. It was an assumption-based model, but this is what they do in RCTs with small sample size, yes, this is accepted. So to get a randomization of 48, they need to enroll 37.5% infants extra. So around 75 to 80 was targeted. So this was well planned. Now let's assume what could be the difference. This is again based on previous studies with seizure control. In one of the study which had 24 participants in placebo, the incidence of seizure was 22. It was a very high rate. In vigabatrin, in 24 infants, the seizures happened only in 5. So the difference between this is the effect size, which was almost 71%. So the previous studies have shown a very large effect size of 71%. With that, they could achieve a power of almost 95%. Now, that's a very good power. But anyone can come up with a question saying, what if vigabatrin was not able to produce this much of good result? What if it produced only 50% less effective? Yes, even if it is 50% less effective, 10 children out of 24 had seizures. Then also the study was powered with more than 90%, which is a very good number. But the question that we arise is, this was not powered formally for the primary cognitive endpoint, but the sample size assumption was more robust for the seizures rather than the cognition part. Here lies a question. So the consort diagram clearly was presented, 84 children, out of which 12 had to be excluded and 72 entered the trial, out of which 4 directly through seizures even before the EEG started showing abnormalities. So they had to be started in an open label group, and 12 did not get a chance to be randomized at all because they did not get EEG abnormality, they did not get seizures. So these two groups, this 4 and these 12, continue to be in the comparison group till the end point of 24 months and the extended end point of 36 months. I'll tell you what 36 months is. So they continue to be there. Rest of the infants got randomized. 29 randomized to vigabatrin group. The remaining 27 got randomized to placebo. So now let's assume the placebo, whoever has been randomized, if they get into one episode of seizure, over a 2-week period, they will be started on vigabatrin, dose escalated to 150 milligram per kg per day, what we start in clinical practice. What they noticed was, one by one, all the infants, whoever was in the placebo group, most of them started getting seizures immediately after this randomization only, with a median of 44-day difference was only there eventually between the two groups. So the study group itself, they have mentioned the placebo group is indirectly a delayed vigabatrin group.
Kaushik, I'll interrupt you here. So I would want your input.
We will discuss later. Why? Yeah.
Kaushik.
Yes.
So with that
what
kind
happens
of
is actually this is
disease, yeah, sorry, you can't hear me, Kaushik. But my question was, there is a disease with a natural history where we expect seizures at a certain point of time.
Yes.
Now, you are saying preemptively we are trying to do EEG, use it as a biomarker, see if there are EEG abnormalities, and start vigabatrin. So anything that you find in the methodology that is not fitting with the natural history, or what do you think about the robustness of the methodology in this situation?
So again, it was planned carefully, but if you ask me whether anything else could have been done, the frequency of the EEG and the duration, the technique of the EEG is what is going to be a query here. They did a 1 hour EEG for all this patient with a sampling rate of almost 2000 hertz has been mentioned. So again, this puts a query on whether the EEG will be able to pick up, this 1 hour EEG will be able to pick up the seizures. IEDs is what one aspect. Second thing is they have been doing EEGs between almost 4 to 6 weeks difference in the first year and every 3 months in the second year. Again, what if the interval seems to be slightly longer to me? Is there anything else? I'm not very sure.
What about the type of EEG abnormalities that they were focused on?
They were focused on, they have specified clearly the spikes, polyspikes, and sharp wave abnormalities. They have not commented much on the background abnormalities. Again, in tuberous sclerosis, we see a very high association of background abnormalities with early seizures and also autism and behavioral problems, encephalopathic states, or early spasms. So I think that could have been more clear. And again, there has not been any correlation with the MRI data has not been provided, whether there were any tubers or cortical tubers or any segas in the initial part, that has not been mentioned. So these all could have been included in the baseline characteristics, and
Kaushik,
that could have
see,
been.
the issue here is, see,
Yes,
you
sir.
have a lot of open label data which shows a very good effect. Okay.
Okay,
So
sir.
you have shown
Okay.
that. So that is on that premise this study is started. So what is the
Yes.
purpose of this study? This purpose of the study is highly biased to show that is it the open label data is actually a real effect, or it's a chance effect, or it's a publication effect, publication
Okay.
bias, or anything. Because as we discussed, you have not pointed out, most of the studies are from some specific centers in those studies. Okay.
Yes.
So this study is primarily tried to show that they wanted to give that this is one of the best studies which we can do at this point. I will say that you can't have a better study because they have actually considered all the possibilities. They considered that if the patient doesn't develop seizures, if the patient develops seizures, but the patient develops EEG abnormalities, you never develops an EEG abnormality. Okay, so with all the possibilities they have tried, and then they have got an effect size calculation based on the previous data and also 50% of that previous data. You can't have a better study than this. But again, the problem here is the chance. Okay, so you have you can see that consort diagram. There are 11 patients never developed EEG abnormality. Okay.
Yes.
So that natural history is difficult to predict because we don't have a clear biomarkers other than this to go around. And then, as you rightly told, because the main problem here is their primary outcome was cognition, and the data was more on seizure outcome.
Seizures.
Okay. So, but what they probably, what I'm not sure what they wanted from that, but probably they felt like the cognitive outcome is a much better thing for a tuberous sclerosis patient rather than a seizure outcome. Okay. So whether seizure and the seizure and cognition will go hand in hand, or these are two different parallel arms, we don't know, or with an overlapping things. So that is the real issue. Otherwise, I would feel like this is what we can do at this point to clearly show that, but it is biased a little against vigabatrin or the treatment arm. That is what I feel in this, because they wanted to be a little give a clear, not so clear chance for the vigabatrin. They wanted to prevent that chance association of a positive outcome. So they were very very strong in that. So that might affect the negative outcome at the end. You can always point out that there might be chances that there are some groups which are benefited, but in the general sense, the study was biased against the intervention arm. So the outcome would have been be affected by that. Okay.
Sir, this Kaushik brought out a point that the interictals that they are trying to see is sharp spike and polyspike. Whereas a very important handle in any child with tuberous sclerosis in that age group is an evolving spasm. So they didn't look at lack of synchrony or high amplitude slow waves, which are very strong handles, or sleep patterns, as you said, background abnormalities, as potential biomarkers for predicting an evolving spasm, IESS. So can that be taken as a shortcoming in the methodology, sir? Because
no, but the problem here is you have to treat, no? So can you treat a slow wave abnormality? Are you justified in treating a slow wave abnormality? Because it is considered a non-epileptic form of abnormality. So at this point, ethically, we will not get an approval to give vigabatrin with a slow wave abnormality. Only if they see, again, you can, even this, how come they got in from US, I am a little this thing. Because the problem is in interictal abnormality per se, it doesn't say that the patient is going to develop seizures.
Exactly.
Only because there are some studies which have shown that there is a very positive thing, and then there is something which is at stake here, which is, and then this is a kind of a revolutionary thought. That is how probably they were able to convince the ethical this thing, because otherwise in a given situation, if you give a non-epileptic patient or a patient never had a seizure, he has got some EEG abnormality or a spike, slow wave, whatever it is, unless it's an absence 3 Hertz spike and wave, it will be very difficult to get a study to start, especially a bad drug like vigabatrin. It is not that easy to get. So I think they were pragmatic. They planned it much better than which could be done, but still there are drawbacks. Any study will have something which is not controlled. So this is that kind of a state. They have managed that ethics committee. If you have put slow wave or any other abnormality, I don't think they will get an approval for starting like that.
Yes, got it.
So similarly, I think something similar to what Sir said, their primary outcome is also focused towards first seizure or a focal seizure more than a spasm. In fact, spasm is not even a predefined marker. So I think
why Kaushik? Why?
Sir, focal seizures in retrospective data overall, focal seizures are very common in tuberous sclerosis than spasms, is what the numbers or statistics are saying. But quite contrary.
That is the same. See, the problem here is if they have taken spasms, they might have needed a much higher numbers here. See, the primary outcome is spasm reduction or prevention of spasm. So they entered for, or they tried for a low-hanging thing. That is, a focal spike indicates a focal seizure, but a focal spike as a what I'll say, a predictor of a spasm, it will be much more difficult to convince the ethics group. Okay. So prevention of a focal seizure would have been much easier to convince again. Okay. So that is also important in when you are doing studies in early infancy. The ethics are very, very, very strong compared to adult studies.
Okay. So coming to the results part, as the efficacy of the EEG biomarker, whatever they have mentioned, they had a sensitivity of more than 0.8, positive and negative predictive value of more than 0.7. And this is in concordance with the similar previous trials. Even Epistop also gave something similar to that of these same results. So we'll discuss more on this EEG part again towards the end. Now here comes a very interesting finding on the baseline characteristics. So among the baseline characteristics, what was very significant is the proportion of tuberous sclerosis 2 gene, TSC2 gene, was more in both the groups, in vigabatrin and placebo, both it was higher, and more so in the vigabatrin than the placebo group. This actually happened by chance. Now, why is it more significant? Because we all know that TSC2 is more severe, more likely to present earlier, and was highest incidence of drug refractory epilepsy. This outcome was not adjusted, maybe it was not anticipated earlier, and the primary outcome parameters with
Kaushik,
relation to the cognitive.
What was your thought?
Yes.
Some thoughts on that? Why TSC2 was more represented here? One possible thought.
Sir, I think the randomization happened. The study inclusion itself is less than 6 months of age infants. So TSC2 is a severe phenotype, and I think it is likely to present with earlier seizures, onset of seizures, spasms, than as compared to TSC1. So that is what came to my mind.
Even possibly that I also feel like that is the reason, because TSC2 will be they present much earlier. Probably they considered that as, so it is a random. No, they are not planned for it. So it suggests that it's a TSC2, probably in the natural history of TSC1 presents a little later and TSC2 presents early.
Okay, so this was actually similar in one of the meta-analysis published in 2025. I'll come back to that data. It was surprisingly correlate with other studies as well. Now, coming back to the primary outcome parameters, there was no difference between the two groups in terms of any of these primary outcome parameters. Just to say pictorially also, you can see that the medians are almost similar. There is not much of statistical difference between the two in terms of cognitive parameters. This primarily turned out to be a negative study. So now the other secondary outcome parameters in terms of seizures, also they did not find any difference between the two groups in terms of onset of seizure, drug refractory epilepsy, and control status. The p-values you can see is all not significant. Now, the same has been represented in the image format. In the Kaplan, what you can see is these two lines. The red one is vigabatrin and the blue one is the placebo group. Almost a very similar course they are traveling, and not much of statistical significance also what we can see. Now comes a very interesting finding. This is the time to first infantile spasm. So although it was not a pre-specified point that we have been discussing so far, they did a post-hoc analysis, more so exploratory parameter, because they found in the vigabatrin group as compared to vigabatrin, the placebo group, there was a very significant difference. So the hazard ratio was 0.26, which means in the early vigabatrin group, 0.26 minus 1 is almost 74%. So in the early vigabatrin group, there was 74% relative reduction in the hazard ratio of getting spasms as compared to the late vigabatrin group. Now, this becomes a very interesting finding. The confidence interval also, if you see, is 0.7, it's less than 1, so it is statistically significant, but unfortunately cannot be interpreted as a main point in the study, because this was a post-hoc analysis. Adverse events, again, between the two groups, only 13 adverse events were reported. Nothing major. Only one child had some vision-related adverse effect. They have mentioned what exactly they have not mentioned. They had to discontinue, but others, nothing major. So let's quickly go through the study with an eye from the Consort 2025 guidelines. So most of the aspects actually we have discussed already, and they're all very good complaint with this protocol. But the study title ideally mentions, it should mention the full design, randomized placebo control trial should have been mentioned here. That is lacking. And some changes with relation to the COVID-related protocol has been done. They have mentioned that, but the impact has not been fully quantified. In fact, they have said that they will publish a follow-up report after analyzing, doing the ADOS to autism-related scores, but that does not come yet, 1 year after the publication also. And the other parameters with relation to the eligibility criteria, sample size, everything has been discussed already. It was properly the randomization, allocation, the study intervention, the choice of statistical analysis, everything seems to be robust and appropriate. Okay, let's come to the strengths of the study. One of the most important strengths is just the completion of the study was a big challenge to recruit a very sensitive age group, and challenging double-blinded design in an infant was just to complete was the biggest strength of the study, I guess. The randomization was a predefined EEG trigger. Whatever they have mentioned, they have even checked inter-rater variability at baseline. There was a high inter-rater variability, and it was done across 13 centers in US. So overall, at least for the Western world, there seems to be some generalizability. And let's see what could have been improved in this. Now, a very interesting meta-analysis came up in 2025 recently. So here, it also showed 3 studies, of which PREVENT was one of the studies. There were 2 other studies I'll explain now. So the TSC2 to TSC1 ratio was almost 8:1 in the preventive group cumulative pooled report. This is comparing to all the 3 studies. So the pattern that we see here is not just exclusive to PREVENT trial. It is something what is reflecting overall, because every study has recruited infants less than 6 months. Naturally, TSC2 is likely to have manifestation. Sample size we have already discussed. So there is no standardized cognitive scale and scores actually, with the results also with a very good effect size. So I think that could have been the reason why they chose seizure-related outcome as a for a sample size calculation. They have chosen a very large effect size. Slightly seems to be an unrealistic expectation. But again, this was based on one previous study. Now, this is the most important point, the limited separation in treatment exposure. Now, at the end point, primary endpoint of 24 months, if you turn back and see, both the treatment vigabatrin arm and the placebo arm, both have received almost for a similar duration. Vigabatrin has been there with a separation of just 44 days, the median of 44 days. Now, this happened because of the study design. This is ethically justified. Now, but this is just diluting the exposure component. The follow-up, neurodevelopmental follow-up again was at 24 months, and they planned one at 36 months, but they could not acquire it because of COVID. Again, the infantile spasm was not pre-specified. So what implications that is carried? Just we have a natural tendency to compare this with one of the most important trial which came up in 2020, EPISTOP trial, one of the landmark trial based on which multiple other preventive studies were started. So PREVENT is the best by design so far as compared to the EPISTOP, because EPISTOP had an open label component. The results were almost hybrid design results were there. But EPISTOP is a trial who focused on seizures, and PREVENT was focusing on cognitive parameters. And EPISTOP came up with positive outcome in relation to seizure related parameters, and our PREVENT trial did not come up with such results. Let's see quickly why this could have happened. And my work was actually made easier with this meta-analysis. Our moderator is on the team here. So what interesting trials they have compared is, this is the PREVENT trial that we are discussing today. This is the EPISTOP trial which came up in 2020. One more prospective trial was studied. So these are 3 preventive trials in tuberous sclerosis so far by a proper design. There are multiple other small case series, but they are not very significant. So if you see, most of them have recruited infants less than 4 months and 6 months, and they have got a decent sample size. And you can see all of them had a TSC2 proportion was significantly higher. The ratio was almost 8:1. Now, quickly the results part, in relation to the seizure, in relation to the spasm, and in relation to the other cognitive outcomes, what we clearly see is the direction is definitely favoring vigabatrin. This side is vigabatrin. Definitely the effect size is favoring vigabatrin, but everything is touching the line of no effect. The confidence interval, everything is including 1. So unfortunately, statistically, we are not able to prove it, but definitely the direction is favoring vigabatrin. Now, what could have gone wrong? EPISTOP is a similar study, why it came up with a positive result, and what could have gone wrong is they too are different studies looking at different endpoints. And PREVENT, we have already said, the exposure dilution has already happened, and EPISTOP has a hybrid design. So they made a pooled analysis, so a lot of chance for getting a selection and site level confounding biases highly possible. Let's see quickly before we conclude, what evidence do we have for focal seizures? Not much of data in the recent years. This was published in 2021. Just see the highlighted parts, what we are mentioning. We are talking about 50% seizure reduction from baseline. The first drug, cannabidiol, was some numbers they were quoting between 30 to 40% efficacy in focal seizures. Again, you see mTOR inhibitors, everolimus, sirolimus, except for one study, other studies were quoting numbers in the range of 28, 40%, 39% is what we are talking about. Similarly, the common drugs that we use in daily practice, lacosamide, clobazam, levetiracetam, they're also as an adjunct for next to vigabatrin, the efficacy was 48% or 51%. So roughly all these studies were quoting only 40 to 50%. There is one study with lamotrigine, 79%, but what evidence are we seeing? It is only 3B evidence. So it may not be very significant to consider. So with regard to the focal seizures, we are talking about efficacy of 40 to 50% as adjunct therapy. Sirolimus is providing a modest evidence with a good 50% reduction. It needs more exploration in the preventive aspect. Now, let's see if somebody is asking me at the end of all these things in the daily practice, can we start using vigabatrin for tuberous sclerosis infants? No, not yet. To be honest, we don't have sufficient evidence statistically. The direction of effect is definitely consistently favoring early vigabatrin, but the evidence is not satisfactory at this point of time. What is the role in spasms? Spasm is the biggest winner of this entity in the whole thing. They have got a very significantly positive outcome with relation to spasm, but again, it is an underpowered outcome in this meta-analysis, what we discussed lately. So again, it needs more studies. And any role in improving cognition? Not it. And can we use this EEG as a biomarker? So far, the positive and negative predictive value of more than 0.70 is a good number that we are looking at. But even the EPISTOP trial that got published in 2020, who was very proud of the EEG parameters, they themselves have mentioned that their video EEG failed to detect the abnormalities before seizure in 23%. It's almost like 1/4 of the study population the EEG has missed. So what is needed is more standardization in the technique, timing, and duration. Again, that is more needed. And what is the biggest take-home message? One thing what we are all very sure is vigabatrin, in all the studies so far, it seems to be safe to use. This is one of the main concerns that everyone is raising, that how long do we use vigabatrin? When do we stop? When do we stop the preventive therapy? All these questions, but no major adverse effects so far. And the knowledge gap is still there, need bigger RCTs. And what is the biggest game changer of the decade is the preventive therapy before the first seizure. Now, we have discussed a lot about tuberous sclerosis, but multiple other conditions like Sturge-Weber and a lot of genetic encephalopathy, even in Angelman, these are conditions where they are considering preventive therapy before the aspect of first seizure. And pediatric neurology, consensus came up in 2023, and they released a corrigendum after this prevent trial has been released. They made a small change to it also. This is recommending developmental outcome assessment every 6 months, 6, 9, 12 months. Yes, it is accepted. And they are also recommending start doing frequent EEG monitoring. In the first 6 months, do it every 4 weeks. In the second 6 months, do it 4 to 8 weeks. In the next year, you do it every 3 months is what they are recommending. So they have come up with a very strong recommendation. And what surprised me was they have even mentioned that pre-symptomatic treatment is now strongly recommended, and that can improve the epilepsy and neurodevelopmental outcome. I'm not very sure. I leave it to the forum for this part for discussion, whether how much significant this recommendation can be taken, because this seems to be quite a strong comment that they have made. So what else can be done in this domain is that we are addressing vigabatrin, but there are many other pathways that we are talking about as mTOR related pathways. So that work has already started, as we are discussing today. Multiple studies are in the verge of conclusion. Actually, the STEPS study, the STOP2, and even the VIRAP, all these studies are in the point of conclusion. We are expecting anytime results towards the end of this year or next year. So they are all trying rapamycin, sirolimus, or everolimus in place of vigabatrin, or comparing with vigabatrin as a preventive therapy in tuberous sclerosis. A lot of questions are yet to be unanswered, like what is the end point of preventive therapy? How long do you keep continuing? And what is the first add-on treatment option after vigabatrin in focal seizures? I think these are questions that need even more wide exploration. Thank you.
Yeah. How much time we have, Jyotsna?
So we can discuss, sir.
So, very good presentation, Kaushik. You have brought out the whole points. So
Yes.
the main thing here is what has changed in tuberous sclerosis now is this early diagnosis, and then we know to a major extent the natural history of this disease. This is one of those genetic disorders. We know which time, which disease, which type of seizure. So almost everything, there is a kind of a timeline is available. But in an individual patient, we don't know which way they are going. And probably there are other modifier things in that. So that we are not very sure. So this PREVENT trial is a very strong trial. I'll say that this is one of the best trials managing the ethical concerns and also the difficulty, the difficulties of doing a trial in that age group, and then looking at the scientific evidence of that, and with a very what I'll say, lot of promise after that epistop and the open label trials. You have to come up with a negative trial, means you have to have that kind of a strong scientific fervor to have that. Otherwise, the usual thing is to go with the bandwagon. So that case, something like somebody has pointed out something, you go with that, you try to do the studies to prove that. It's kind of a kind of echoing effect will be there most of the time. The second study will be an echoing effect. But here, so the cognitive thing is very clear. See, the point is vigabatrin is a anti-seizure drug. So if you are doing an anti-seizure, if you are giving an anti-seizure drug early, and then you see that seizures can be stopped or prevented, there is no major issues in that, because we know that. Because if you have an anti-seizure drug, the seizure is going to be less in that group. It should be. Okay. Because we are trying to prevent, just like something like you give paracetamol, you are expecting fever in a viral infection, you give preventive paracetamol, that group will be theoretically should have less fever. In that case, the only thing is paracetamol should be effective in that that kind of pyrexia. If it is some other pyrexia, which is where paracetamol is not effective, both will have the same thing. So here, that is why the PREVENT trial is trying to look at the hard outcome of a cognitive thing, which unfortunately we have failed. That is not very unusual, because most of our trials to look at the developmental outcome, whether it is SPASM, the ISIS trial, UKIS trial, any trial where you look at the long-term developmental outcome, all the studies have failed, probably, which shows that once we start treatment, by the time the brain has already changed and the outcome has already occurred. So this is now the question here is when to start treatment, whether it's at the first EEG, or if we can show that vigabatrin is very effective, or we have a better drug, every child with tuberous sclerosis, whether we should give that drug so that they will have a better cognitive outcome in the long run. But the only problem with that kind of an approach is we don't know there are a lot of heterogeneity here in the TS group, you know that. But if you have a TSC2, and then we can do a preventive therapy without an EEG, that will be the best, I think, the next trial, rather than waiting for an EEG. If you have a better treatment option, you say that vigabatrin is not showing that kind of a side effect. The first 1 year is very important. You start every child with a TSC2, a vigabatrin treatment, whether that will make the cognition better. I would be interested to see that, because that is, as a researcher, because here I started saying that in the GPS trial, I will not be that interested in the next thing. But here, since this is my bread and butter as a researcher, as a clinician, my interest will be knowing that with all these things, no EEG, nothing, you start vigabatrin and the cognitive outcome is better or not. Whether the ethics approval we will get or not is the question. That depends on whether we will get more and more open label data, and then we have more and more open label long-term data, and shows that vigabatrin is not that bad over 1 or 2 years. If you get that data, that will be the best thing, because the spasms can be prevented, seizures might be less if you start, because the thing is, placebo patients, most of them ended up in delayed vigabatrin. That is the other thing in this group, which says that there is a very high chance of developing seizures in this group. Okay. So what else? I wanted to tell one more thing. I forgot. Maybe any other persons, Jitupam, you tell us.
Yes.
Any thoughts?
To interpret, I mean, to take home message from this paper, I feel as it is showing no difference between the control and the study group. But the thing is, like, most of the patients who were given placebo, ultimately before the primary endpoint, they end up receiving vigabatrin. So actually, I don't know how much is the difference between the actual treatment group versus the placebo group. So to interpret it that there is no difference between the treatment vigabatrin versus placebo, it is very difficult to say that there is no difference actually. So I will take it like that to just negate the effect that there is no effect of vigabatrin in cognitive or seizure outcome, but or focal seizure also. I feel there would be some kind of benefit with vigabatrin, because this, though it is labeled as vigabatrin versus placebo, actually I feel there is not much of difference, because before primary endpoint, ultimately most of the patient, they end up receiving vigabatrin. So the result is, I think it is showing more negative what it should be actually.
Yeah, see, that is why the trial is a little biased not to show, because it is a kind of, there are a lot of data which is showing, so they don't want a chance association. That's why it has become a very, very strong, very, I think, rigorous trial with a bias against vigabatrin. That's why Priyanka has done that meta-analysis. There are a lot of takers. I got a lot of feelers from the West saying that that is one of the best things you did along with this thing. So that shows that, see, this is something like a study where you feel like that is there, but unfortunately this trial was a rigorous trial. It was not shown that effect, but still there is a scope. The scope comes from there are two issues. One is whether to wait for that EEG abnormality, because we know that a TSC2 will have a bad outcome if they are presenting very early. So you start treatment then and there, or you have a kind of an any EEG abnormality, you start treatment.
And
From a
like that is
practical
also not
point of view,
possible. Yeah, that is not possible to, I mean, to rectify this kind of effect because the study design and from ethical point of view also, you just can't stop and see that patient is having electrographic seizure or clinical seizure, and because that patient is placed in placebo, you just wait for primary endpoint. So I think in most of the epilepsy studies, this kind of ethical issues will be there, and we have to take the result with.
Yeah, definitely. See, the point here is this is not a negative. In that phase, I feel like the take home is vigabatrin study in tuberous sclerosis is not going to, vigabatrin treatment in tuberous sclerosis is not going to go away with this study. That is for sure. Okay, because there is a strong recommendation from the European group. They strongly feel, but the only thing is where to start, when to start. So the one take home now is do EEGs regularly. There is no doubt about that. If you have a child who have diagnosed, you have concluded that very clearly. You do that is there is a strong evidence now. So you do the EEGs early and then see that whether the EEG is getting abnormal, then you can start treatment. No doubt about that. So that is according to this trial has also shown that it is better to start. But whether it will change the overall cognitive thing in a given patient, we can't say at this point, but we hope that will be possible. There might be better trials. So any other things?
Again,
and if anybody who is interested, just see the meta-analysis paper because that gives that thing clearly. Okay, Kaushik, that Jitapam, anything? You were telling something.
No, sir, I am done. Actually, Kaushik was telling something.
Sir, actually, this is based on the assumption that the seizures cognition is likely to worsen because of recurrent seizures, drug refractoriness, and finally going for epileptic encephalopathy is one mechanism. But as you rightly said, the tuberous sclerosis is something like there are other mechanisms which can cause cognitive impact even without seizures also. So I think simultaneously working on mTAR pathway and even beyond mTAR pathway is something to be explored for.
Yeah, so it all depends on the safety efficacy thing, no? So the safety factor comes into the picture. So if you go for a pre-symptomatic therapy, always the safety comes first or before efficacy. Okay, so we may have to show that safety is it is a safe treatment rather than an effective treatment. Because if we are going to treat, if we want to treat to prevent one patient from developing a cognitive effect, that is a great thing, provided the rest of the patients are not developing major safety concerns. Okay, so that is one issue whenever we are going for a preventative therapy versus a curative therapy. Curative therapy, always we are willing to take that risk to a major extent depending on the seriousness of the condition. Whenever you are having a preventive therapy, you don't want anybody to develop a major complication. Okay, so that safety signals should be very, very strong. But at this point, safety signals are strong. Only time will tell whether that for the time being, there are long-term data on vigabatrin in tuberous sclerosis, years and years of data that has shown that there is no major issues. So, and we know that the first 1 year is very, very critical for neurodevelopment. So in that way, a 1 year exposure, if you can show that the cognitive outcome is better after that, you can prevent spasms in a significant number of patients, probably that is going to stay. So that is the next level of probably the studies will come, or at least open label you can expect in the near future. People starting without EEG abnormalities with the parental consent. The moment you get a rhabdomyoma, you start vigabatrin. There is a chance that we will get those kind of papers in the near future. That's my prediction in this.
Dr. Jasmine
Sir,
has a question.
Yeah. So disclaimer before the question is that I am a adult neurologist. So, sir, I want to ask patient reduced, like not significant, like, about the focal seizures, but there was some significance about the epileptic spasms. What I have the understanding is that in the infant group, the patients who have infantile spasms can also have a focal region. They initially they are infantile spasms, and then they evolve finally into a focal form of semiology. So is it do you think that the results would have been different if the parameter considered as the outcome was focal plus epileptic spasms? Because we saw that the epileptic spasms have got a little significant result. So do you think the results would have been different if both the types of semiologies would have been taken together?
Probably, see, what they wanted to look at here is, see, the simple thing here, there are 2-3 issues here. Vigabatrin is an effective drug for spasms. That's for sure. No? So somebody who has started on Vigabatrin earlier, if they have got a lesser number of spasms, doesn't tell you that the kind of you are already exposing. But the problem here is in tuberous sclerosis, multiple ways the spasms can occur. It can occur with a strategically placed tuber, which is actually a focal seizure, which is expressing as spasms, or it is because of an epileptic encephalopathy. So both are possible in tuberous sclerosis. It's not like a standard, what I'll say, spasm syndrome alone. Both focal origin spasms and the epileptic and IESS both can occur in tuberous sclerosis. So probably spasms, if they have taken the number, the numbers needed to produce, so show that effect would have been higher. That is my feeling, but I'm not very sure in that.
And just another comment here, Kaushik, you had presented it very beautifully, and with all the background and discussion along, it really was very enlightening. So your report, your critical appraisal was in the consort form. I think that the consort is primarily a reporting thing. So you have actually covered that everything was reported, but when you critically analyze, consort is not the ideal thing. You have done it, and it is good that a consort was also covered, but it is difficult from critically appraising a study. Sir, what do you think, sir? Because
See,
what is actually
consort is primarily to look at the parameters, whether they have done it properly.
Yeah.
Okay, that they've done it. It's more of a internal validity kind of a thing, whether they have done everything properly.
Yes.
So for critically appraising, some things might get missed when you're just looking at consort, like, was the question relevant? Was the question asked? Did they cover all the components? So that there is a little bit of difference. So maybe you can go back and check. So our audience should not get that, consort is actually a critical appraisal tool. It is a reporting tool.
Okay, sure.
Okay. Great session, I'll say. So lot of questions, lot of interesting things. Okay, so the bottom line, I will try to say that there are no ideal study. So any study we can criticize, there will be loops, and whatever, if there is a kind of a signal, that signal is to be taken up in the next thing. So there are no ideal studies in the world. We can't design an ideal study. Anything else from the Saraswati, Jyotsna?
I think we have one question.
I had a vision. Yes, Dr. Jasmine, tell it.
There is one question in the chat box, if you could take that.
Yeah. What is it? Could you read it? I can't see.
Okay, so the question is carbamazepine or valparin, which is more effective? Thanks.
Okay.
Maybe
it is not mentioned for focal seizure or in a TSC case in specific or in general.
No, that's all.
So there is a question from Kalpana. See, the question is, here the placebo group, vigabatrin was started after a seizure. Okay,
yes.
What is your thoughts on that? Whether it will affect the primary outcome or it will not affect the primary outcome?
Again, the timing has been almost very similar, sir. Like
close
in the early
time.
group and lead group, very close time only. So I think that's why the exposure itself has been almost similar. I think it would have not disturbed the outcome assessment, is what I think.
No. See, the outcome was, primary outcome is what?
cognitive measures.
At what age?
12 months and 24 months.
See, then now you say the answer. Whether it could have affected on the placebo or the delayed arm, because you have two arms there, no? So you have a 12-month outcome. Okay. And then the gap between the placebo, the mean duration was only 44 days. Okay. But and the other two groups received months and months of both the drugs received months and months of vigabatrin. So it will have an effect, it will not have an effect on the cognitive outcome if there is if they want to show an effect size between two arms.
Again, they have mentioned the time to first seizure has been mentioned, sir. What also matters is the number of seizures that the placebo group keeps getting, and cumulatively that could have affected. All that is not there.
Yeah, so that is the problem. So probably my take on that is there is a chance that, say, the result would have been much stronger if they have not given the vigabatrin on the placebo side. But that is not possible because of the EPISTOP trial. Okay, because there is another trial which shows that vigabatrin is effective. So they can do a pure placebo study on the pure placebo study. The moment the patient develops a seizure, because you have to, EPISTOP trial is also there, and then there is a standard practice also is to give treatment after the spasm. You can't give weight because the outcome is cognitive outcome. Okay, primary outcome is cognitive outcome, means definitely vigabatrin treatment, both sides would have reduced that equally. So the defect size will become less between the two things. Comparison becomes difficult because both are getting exposed to the same intervention for a long time. Got it, Kaushik, what I am trying to say?
Yes, yes, sir.
So the seizure outcome is different. You are looking at the cognitive outcome, means both the groups have received several months of vigabatrin. So if the vigabatrin has an effect on the seizure control and the cognitive outcome, because it has got an effect on the mTOR pathway, so probably both sides will get that effect now.
Yes.
So the comparison will be, so there will not be any major difference because of that also, because there are multiple reasons. This is also might have contributed to that.
Okay.
Okay.
Yes, sir.
Okay. So,
sir, one last question.
Yes,
sir. So in your daily practice, like in difficult focal seizures in tuberous sclerosis after vigabatrin, what is your next go-to drug, sir, like between the options?
There is no real answer. See, you don't have, you can try whatever this thing, you go for cannabidiol nowadays. Okay. Because then the next question is definitely more, my thing is to look for a possible surgical thing. If it is focal. Surgically, so that will be the first way I would look at it, because TS is primarily a focal epilepsy. So my first take is, if it is not working, there is a focal seizure. Is it a clearly focal or it's multifocal? In an epileptic encephalopathy, it becomes much more difficult. We will not get that focality.
So I think there is a famous quotation that sir always says that the peruka, I think, with that football example, sir, every kick you hope that it is a goal, but then if it is not, then you go to the next drug. So in a drug-resistant epilepsy scenario, we are definitely not using, hopefully not using the wrong medicines, which is going to worsen an epileptic encephalopathy with the focal epilepsy. With that knowledge, whatever drug you can use, I think that is the way. Is it, sir? Is that how we
see, but we are moving much better. So 10 years, 20 years back, we were like that. It's like whatever stone you get, you just throw it off. But now we are becoming better and better. Probably will become better, much better in the coming years. But there should be a plan. If it is a focal epilepsy, always try for a surgically remediable center. Jasmine, anything to add from your end?
Yes, sir. Refer as early as possible for surgery if two drugs are not working, because we have seen like a delay in just referral for 10 years, and then another waiting period for 3 years, 4 years, 5 years. So after 2 drugs, just refer for surgery. Maybe by the time the patient is waiting, we can keep having the trial of the drugs. But yes, refer for surgery once you have failed after 2 appropriately selected drugs in the maximum tolerable dose.
And then the stake is very high in the early age. So try to do it as early as possible. So with that, so back to the organizers, Saraswati, you conclude.
Thank you very much, sir. I think the session has done an excellent job on cultivating reasoning. And as we have seen today, every trial which is trying to answer one question is opening up many more questions to us. So we will go a long way while we analyze these trials and while we apply them in clinical practice. A very enriching, intellectually honest discussion. Thank you to all the moderators for this. Over to Jyotsna.
Thank you, sir, for this wonderful discussion. I had a vision before the session. What I had experienced or benefited being a PG student for long years in Amrita, I wanted to give it to the young neurologists across India. I think that job is done, and the purpose
Too much,
of me.
Okay.
No, that is that was the vision towards the session. And Dr. Jasmine, Dr. Jitupam, Dr. Pooja ma'am, you have all involved to a major extent, and you have enriched the discussions by asking very pertinent questions and bringing out pertinent points from the studies. Dr. Kaushik and Dr. Shivam have done a great job of presentation. It is not easy. It requires a lot of courage to go to a national audience. I thank one and all of you to make who are involved in making this a very enriching session. But we have interesting sessions lined up for you in the near future. Along with the academic sessions, we also have parallel offbeat sessions like this. And if you want any of such kind of sessions which are not looking the usual, please reach out to us, DM us, and tell us what you want, and we will hope to deliver. Thank you, one and all. We close this session. Thank you, sir. Thank you, Jasmine.
Thank you, sir.
Thank you,
Thank you.
Saraswati.
Before we close, sir, I just want to have a big, appreciation for Dr. Saraswati and Dr. Jyotsna. There has been a lot of, to and fro and meetings to make this session, go well. And congratulations to both of you. Thank you so
They
much.
make a great team, I think.
Yeah.
Yes,
Thank you, sir.
absolutely.
And our next session is scheduled for March 8th. We'll look forward to see you all there. Thank you so much. Thank you so much, everybody, for joining us.
Thank you.
Thank you, ma'am. Thank you.
Thank you.